All right, we are recording. Travis, can you hear me?
Yes, I can. Sorry, I was muted.
No, you're fine. Just so you know, I'll go ahead and just keep controls during our presentation. And so if you want to just let me know when to forward, or I can gauge by whenever you're done speaking, but it'll probably just be easier if I do it.
Yeah, that sounds great. Thank you.
All right. Hello, everyone on the call. It's about 11:27 here Central Time. We're going to get started in about 3 minutes. Just a reminder, if you are not speaking, to please put your phone on mute to avoid any background noise while the speakers are presenting. Thank you very much. Hello, everyone. It's about 11:30 Central Time. We're going to get started here in a minute with our learning session 1 for the PECC Collaborative. Just a reminder, if you are not speaking, to please make sure you put your phone on mute to avoid any background noise during the speaker, so that it's not a distraction. Also, if you are on your computer audio, make sure that is also muted, as that sometimes will cause some interference and background noise as well. We definitely recommend calling in on your phone, as that decreases interference. All right, so we're going to go ahead and get started. Is there a question? All right, just a reminder to definitely put those phones on mute so we avoid that background noise. All right, so we're going to go ahead and get started with our Prehospital PECC Collaborative Learning Session number 1. Thank you for joining us this morning. Just our acknowledgement and HRSA disclosure. The Health Resources and Services Administration, HRSA, Maternal Child Health Bureau, EMS for Children, programs EIAC is supported in part by the HRSA of the United States Department of Health and Human Services under grant number U07MC29829. This information or content and conclusions are those of the author or authors and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. Again, just a housekeeping, and for those that are just joining, do make sure that you put those phones on mute to avoid any background noise. And again, we appreciate you being here with us this morning, and we're going to go ahead and get started.
All righty. Well, hello, everyone. This is Sam, and thank you for joining our first learning session. So for our learning objectives for today are that after this webinar, you'll be able to do the following: define who and what a pre-hospital pediatric emergency care coordinator is, identify the roles and responsibilities of a pre-hospital PECC according to the literature, understand the model for improvement and how it applies to your work in this collaborative and other projects, and understand what an elevator pitch is and how it applies to your recruitment efforts. So the EIAC, HRSA, and NEDARC has been meeting to discuss the definition of what a pre-hospital PECC is. So what we have come up with is that the definition will allow for the terminology individual or individuals, and we will retain the use of the phrase pediatric emergency care coordinator or coordinators, and it will include regional PECC models as a successful adoption of the intervention. And although the primary focus of the collaborative is to increase the number of EMS agencies who respond yes, that they do have an individual or individuals who are responsible for coordinating pediatric care, the collaborative will be collecting deeper contextual information, such as which key roles are designated to what type of provider, variations according to urbanicity, average pediatric run count, what their administrative institution is, such as are they fire-based, third service, hospital-based, and beyond. And at the end of the project, we'll be creating a menu of staffing strategies which will help other states understand how best to help EMS agencies adopt the intervention according to their state's needs. So our next speaker is Dr. Tony Gross. Dr. Gross is currently the Clinical Associate Professor of Child Health at the University of Arizona College of Medicine in Phoenix. She's the Associate Director for the Phoenix Children's Hospital Emergency Department and the Base Hospital Medical Director. And she is the Medical Director of Emergency Preparedness and is also the Assistant Pediatric Emergency Medicine Fellowship Director there. However, as of November 5th, Dr. Gross will be the new Medical Director of the Emergency Department for the Children's Hospital of New Orleans. So congratulations to Dr. Gross and welcome.
Thanks, Sam. And thank you for that introduction. I'm just going to wait to get control of the mouse.
Dr. Gross, you have control.
I have control. Good. Okay, very good. Thank you.
And this is Doug Kupas. I've joined by phone.
All right, so the objectives for this portion of the webinar are to describe the evidence that was synthesized in the National Association of EMS Physicians resource document that was called or that is called Coordination of Pediatric Emergency Care and EMS Systems, and then to correlate the recommendations and evidence with the HRSA EMS for Children performance measures. This resource document was published online in January of 2017 and then published in print in the May-June issue of Prehospital Emergency Care. It was a systematic review of the literature. It is distinguished from the NAEMSP position statement because this is a peer-reviewed document, so it does not necessarily require board approval, but its intent is to provide the evidence and the basis for the position that the board of NAEMSP did approve in the position statement. The goal of the paper was to describe the evidence for coordination of pediatric care across the emergency care continuum. The introduction of the document pointed out that the 2006 Institute of Medicine report had defined what the purpose of an EMS PECC would be, which would be to provide oversight of EMS activities related to the care of children, as well as to promote the integration of pediatric elements into day-to-day services and disaster planning and promote education in pediatric skills and knowledge. It noted that the EMS for Children program performance measures, there was a new set of standards implemented in 2017, which include having pediatric emergency care coordination for EMS agencies. And I think we're all very familiar with this new performance measure as it's defined by HRSA. The study objective I mentioned briefly was to perform a systematic review of the literature and determine how the literature had defined the role of the individual or group that would coordinate pediatric care within EMS systems. It was also meant to provide information that could assist EMS agencies with the establishment of a PECC role and or a pediatric advisory committee role. During the discussion portion of the paper, after the synthesis of the literature, the paper will explain to you that the presence of a physician or nurse PECC was associated with higher pediatric readiness scores and increased compliance with national guidelines for the care of children in emergency departments. And it included specifically the presence of equipment and medications, the presence of staff who were trained appropriately, having staff competency evaluations, having pediatric patient safety measures in place, and key policies or procedures. The literature that was synthesized, really out of 145 references that were identified, it was narrowed down to 9 that met inclusion criteria. And it's probably not surprising that of those 9 studies, none of them were performed in the pre-hospital setting. So these factors that were associated with higher scores, we are taking from emergency medicine and disaster planning literature and applying to the EMS setting. And that was noted in the discussion that these same benefits that were noted for statewide disaster planning efforts or for hospital emergency departments, we should expect those also to be realized in pre-hospital EMS systems, and that having a PECC may be even more important for EMS systems where the volume of pediatric patients is an even smaller proportion than in hospital emergency departments. Historically, up to maybe 10% of EMS encounters are with pediatric patients, and the benefits of having a PECC were realized in emergency departments across the volume continuum, but especially in small volume emergency departments. And then the discussion also noted the HRSA goals that we're also familiar with for the percentage of EMS agencies that will have a designated individual coordinating pediatric care in 2020 through 2026. The resource document went on and has some more information that you will probably find useful. It suggested the role of the EMS PECC would be to identify gaps and ensure resources to care for children are available, to maintain a relationship with the state EMS for Children infrastructure, to establish and maintain offline and online pediatric EMS protocols, and to establish quality improvement plans with pediatric-specific indicators. In addition, some other possibilities for the role of the PECC were identified, and that would include liaising with hospitals, coordinating with dispatch to provide pre-arrival instructions, reviewing medications and devices available for children, assisting in education and training, and working with state and local authorities to address disaster needs. It also noted what Sam defined earlier as the PECC role, which may be shared within, it may be a shared role within one agency or a role that is shared between agencies. and it may be complemented by a pediatric advisory committee. It further went to note the qualifications for a PECC, which should include a background in pediatrics, emergency medicine, or pediatric emergency medicine, or EMS, and a clear understanding of the clinical practice and administrative aspects of EMS systems with an understanding of the EMS scope of practice. The resources that were provided in this document are listed in Table 2. They are many, and they are all footnoted there, and so that's a resource that I think is going to be helpful for starting this PECC collaborative. And in conclusion, the paper noted that the pre-hospital care of children does require coordination, and that future research into best practices is going to be critical to evaluate the impact of a PECC within EMS systems, because the paper was not able to identify any research specific to EMS systems. And I think that is the last part of this presentation.
All right, thank you, Dr. Gross. Travis, would you like to introduce yourself?
Sure. Good morning, everybody. My name is Travis Adams. I'm a pediatric emergency care coordinator with Gaston County EMS. My background is 15 years as a paramedic in field education and management, and I'm going into my third year as an RN in pediatric critical care as well. So I have multiple roles at our agency, including protocol development, some QI and training duties, and then one of my goals is to facilitate pediatric care with some education and quality improvement initiatives. So some background on our agency is we're a county government ALS service. We're one county to the west of Charlotte, North Carolina. We have a tiered response system. So we're the only ALS provider in our county, and we also have BLS services that supplement for 911 response. We have about 45,000 annual calls for the county. That breaks down to 37,000 for our ALS units. We have about 170 employees. And then specifically our pediatric population, when we're talking about less than 18 years, is 10,800 calls per year. And then less than 14, which is what we use as our definition for pediatric patients, is 10,400. So 29% of our overall call volume for our GIMS ALS unit responses in the past year for those less than 18 years old. So I'm happy to discuss some of the successes and deficiencies and some of the things that we struggled with on the local level and answer any questions that anybody has at the end of the presentation.
All right, thank you, Travis. And hello, my name is Cassidy Pennon. I'm an education coordinator for the EIC with the Texas Children's Hospital here in Houston, Texas. Over the next 10 or so slides, I will introduce a basic overview of quality improvement science. As this might be a new topic for many on the call, I will discuss the concept, including a real-world relatable example, and then Travis will then follow up with his experience using the quality improvement in his role as a PECC. So quality improvement in its simplest form identifies a problem and then walks you through the what, why, and how to fix that problem. You do so by examining these three questions. 1, what are you trying to accomplish? 2, how will you know that a change is an improvement? And 3, what change can we make that will result in an improvement? And I'll turn it over to Travis to discuss his experience with QI.
Sure. So some of the reasons that we wanted to designate PECC and also just focus on pediatric care is that we had some people that had some problems either in medication error form that we found out after the fact, and then also kind of evaluating beforehand with some skills workshops and direct observations with some testing that I'll kind of talk about throughout the presentation. So the overall flow of just trying to identify what our opportunities are and then put something in place to change it and then evaluate it and then see if we need to do something different is kind of the whole principle for evaluating some of these things. So many of ours came from training sessions, direct observation, our QI process, and then some employee feedback and surveys. So just different things that we learned throughout the processes.
All right, so the first question is, what am I trying to accomplish? So an example that many of us can relate to is arriving to work on time. Most days I try getting in by 8 a.m., and some days are more successful than others. So I want to use quality improvement to figure out the best way of achieving my goal. The first step is to write that goal or aim statement. Every aim statement should be SMART. That stands for specific, measurable, actionable, realistic, and timely. So for this example, let's work with, over the next 2 weeks, I will arrive to work by 8 a.m. or at least 8 out of the 10 days. We want our aim statements to be SMART so we have a way to determine success and measure that success.
So some of the things that we did on the local level was just overall increasing education and then breaking down what was larger education into smaller.
It's the first education webinar through this new collaborative that Sam's in charge of.
Whoever is speaking, if you could put yourself on mute.
So focusing on increasing education and then breaking down some of our education into smaller skills workshops. So that's where kind of the birthplace of a lot of these types of SMART goals and the things that we tried to figure out what we were going to accomplish came from. And a lot of that has developed out of it. So sometimes during the process, you find out more information than what the actual results are of what you were initially trying to evaluate. So I think it's important to ask a lot of questions during this. Specifically for us, some of the improvement areas that we've done were focused on medication administration and calculation, where we had some deficiencies with some of our personnel. And that included education, follow-up with resources. We ultimately implemented the HANTEVI system, and then just really focusing on protocol compliance and education on base knowledge. Some additional areas that we really kind of honed in on over the past year was safe transport of pediatric patients and making sure that we have the proper equipment. So adding a PD-mate and neomate so that we can safely transport pediatric patients. And then additional education on things that require compliance, so child maltreatment, and then compliance with our protocols. And we added a video laryngoscope system within the past year as well, so that we're able to review live video intubations. So these goals or what you're investigating can come from a lot of different places. And for us, that's how that worked out, that we had different what we saw as issues or opportunities come up and then translated that into multiple different areas to affect the care of pediatric patients.
All right, so how will you know if you've made an improvement? You will need to consult your data. Data can range from the simple to complex. Say you want to determine baseline knowledge of concussion protocols. You would administer a survey to all of your providers. You can't know what improvement goals to make without understanding where you are starting from. In our example, I determined through observation and evaluation of my timesheets that in the past 2 weeks, I only made it to work on time 6 of the 10 days. So a comfortable intervention goal is making my post-intervention be 8 out of 10 days or a 20% improvement.
And so, again, some of the sources that we got specifically for evaluating it can come from surveys, anything from SurveyMonkey, like free resources that are out there that you can use. And then also looking at our data from our PCR system. So we use generated reports that have really sped up our process for reviewing our data and then identifying where some of those issues are after, initially going through it. So if there's a large amount of calls that you're trying to review, really using the PCR software to its full extent and having generated reports. In my case, I review all of our pediatric patients' PCRs. So those get filtered out and then sent to me in a report. And things like that are really helpful when you're trying to navigate large amounts of data. But then also looking at it with direct observation, data could be simple as, we broke it down into smaller skills workshops so that we had lower instructor to student ratios. And then once we started to really evaluate just from either skills competencies or some individual testing, we were able to get data from that to see what our opportunities were, and then also to repeat that at the end to see that the providers were more comfortable, that their accuracy was higher with medication administration, or whatever the skill or device is that they're using. So using the same method before and after has also been helpful for us as well to measure the different types of improvement.
QI Science provides several tools for you to work through the why and how of the problem. Using a key driver diagram could help me identify a few drivers to me being late. Drivers are the what. What is causing my tardiness? Maybe I'm staying up too late watching TV, causing me to oversleep. A possible intervention could be to take the TV out of the bedroom. Maybe I'm not taking the fastest route to work. An intervention there could be to identify alternate routes and test those and time those to see the fastest way. A process map allows you to examine how something is currently done to determine if there is a better way. Maybe my morning routine is slowing me down. Maybe there are things I can do at night to save time in the morning. A process map allows you to make those connections. A fishbone diagram determines cause and effect, with the body of the fish being the cause and the head of the fish being the effect. As you see from the example on the screen, it's also very important to get stakeholder approval and support. It's an even harder task to go it alone. Stakeholders can provide support, break down barriers to your interventions, and can be a champion for the financial support that you will need along the way to develop and implement those interventions.
And for our pediatric care locally, a lot of these concepts and tools help to navigate and organize the process. So everybody's working to do more with less. And so any of the tools or technology that you can use to speed that up or to help organize it is going to save time and increase efficiency. So that can be really helpful. Some of the processes and looking at how things are done, we had evaluating with regards to our engineering controls and some different things with storage of medications and standardizing some of that from a medication error standpoint to just making sure that all the equipment was available. So simple things that we might not normally capture is more helpful when you can put that out on paper, or you can use different tools and concepts to help organize and tackle some of these issues, because we do know that there's a lot of factors that go into trying to make improvements and different problems or opportunities that we may come across. So as far as team development, one of the things that we have is a strong relationship with our local hospital, and then trying to build off of educational programs. So we have a pharmacy residency program that's emergency medicine specific. So they're always looking for projects that can help. So we can tie in some pediatric projects there, our local community college. So some of the resources that we have, really just trying to build those relationships and get more people involved and get buy-in from them to help improve our outcomes.
Okay, so now that you've identified all your causes, your how to make the changes, and recruited people for support, it's time to employ an intervention. The plan, do, study, act of QI Science. The first small change is to pack your lunch at night instead of the morning. While this does save time, you discover yourself still arriving after 8. This is what sets QI Science aside from research. PDSAs are meant to be quick, small changes to determine quickly and in a timely manner if those interventions are successful, rather than it being 7, 8, or even a year down the road and the problem still exists. In this case, since you did save time, you decide to adopt and adapt the change and partner with another intervention and another PDSA cycle.
And so it's important to remember with these cycles that, the testing or evaluation could be something as simple as repeating what the initial test was. So if you had a skills workshop and you identified deficiencies, or you had certain types of errors that were coming up, then just being able to trend that and reevaluate, breaking that down into more simple, practical goals is something that's very easy to do. So some of the concepts can be a little overwhelming at times, but really just the evaluation before and after the intervention is going to give you information on whether you want to keep doing that, if you need to change it up, or to stop doing that. So some of our measures are still in place since the changes, and our protocol changes, and then we are also monitor regularly at peer review sessions. So just continuing to follow up and monitor that data and make sure that you're evaluating those interventions. Again, technology is something that's incredibly helpful. EPCR reports and some of the capabilities with that now to generate standardized reports is incredible to speed up the process. So if there's certain things with compliance, then you can put certain filters into there, and it's going to give you some of the things to look at. So it can help to narrow that down to really workable, effective solutions that don't take a whole lot of time or extra work to find what those are. And then you can focus on what the actual improvement is and actual application of it.
All right, so after every PDSA cycle, it's important to review your results and continue ways to improve. So we determined that packing my lunch at night did save time, but ultimately not enough. And it's further intervention needed to occur to save more time and get me to work by 8. It's also important to think about sustainability. If your intervention adds a time burden or financial cost that the results do not justify, you may have a difficult time having long-term adoption. And don't be afraid to celebrate your successes. The successes, as well as the ones that maybe don't go as planned, are what you learn most from in order to implement that intervention for the future and have that sustainability.
I think sometimes evaluating your conclusion and your outcomes can be using some subjective data, just as far as how our EMS field providers, how they feel about it. So usually when we have a pediatric call where they've used one of our new systems in place as a reference, then I'll send out an email and just, hey, how did this go? What was things like? And so getting that, one, they're feeling engaged, but we're able to learn things after the fact. So just that quick follow-up and short conversations can sometimes give you really valuable information as well, in addition to in-depth reviews after the fact. So sometimes just learning throughout the process gives you more information as well than just looking at one piece of data or what your question was for that outcome. So I think it's been helpful for us to really get buy-in with those who are interested in pediatric care. So incorporating, our team with those that are most passionate about pediatric and have a personal tie-in to care for pediatric patients. And it certainly takes a team of us at our organization to make a lot of these changes happen. And then we're still looking to see what those outcomes look like and how things develop from here.
So as you start applying QI science to your professional improvement goals, you'll find that having a strong and organized project plan will serve you well. Rely on your team to assign tasks, create timelines of deliverables, and always take time to communicate your successes, barriers, and frustrations. When you pull people into a team like that, you never know, they may have gone through the same barriers that you have, and they can walk you through it, and they can get you to avoid all that stress of trying to implement this change. So really rely upon your team and apply this knowledge with them, and you will definitely have success.
I agree with the points Cassie made on this. There's just a lot of this comes down to teamwork and communication, and then really just being able to focus on what you can actually do and what's realistic to be done, and then identifying those wins and the barriers as well throughout the process.
All right, thanks, Travis. We really definitely appreciate your applying this knowledge and sharing that what you learned with everybody on the call.
Oh, you're welcome. Thank you for having me.
So if you have a continued interest in quality improvement, we can give you access to the Institute for Healthcare Improvement QI modules. These are self-paced online modules that provide CE and a professional development completion certificate. So if that is something you're interested in, we have a poll that will be popping up in your chat box. Just feel free to put your email address when you answer that poll, and we can actually send you information on how to access those modules and take them. I also recommend the resource books seen on the screen, the Improvement Guide. This is what we use to teach and model our quality improvement training here at Texas Children's Hospital. So that's definitely something that we recommend for you to get and to use in your everyday practice. All right, so let's move on to an elevator pitch. Sam mentioned this briefly in the overall objectives. And so moving on from the QI Science, we would like to introduce this new concept to you. Start thinking of it and preparing, as I believe in the in-person meeting in Austin this January, you're actually going to be asked to present your own elevator pitch. Think of a good elevator pitch as a verbal business card for your project. If you were stuck on an elevator with a potential supporter or stakeholder and had just 90 seconds to gain their support, what would you say? Keep your points focused and succinct. What main takeaways do you want them to know? Why is this topic important to you, and why should they care? And what action do they need to take after you leave them? Our ask is that you begin thinking about this elevator pitch, what you want to say, and put something down on paper. Like I said, this will be when you get to shine and you get to show your elevator pitch during that Austin meeting in January. So you'll get to develop and present your PECC pitch to the entire group. All right. So I'll go ahead and give it over to Dr. Arbach, who will talk about the takeaway messages for the day.
Thank you. Can everyone hear me okay?
Yes.
Excellent. So thank you so much, and I appreciate the wonderful job that the team did presenting the work so far, and really wanted to hopefully bring some things together as well as hear some feedback from the group here. Really, what are the three take-home messages that you learned from today's presentation? The idea here is that it allows for us to have a little bit of a cross-check with the team in terms of, you're participating in this session. What are the key take-home points? What questions may you still have? And this will help us to guide both the content for the in-person meeting in Texas as well as future webinar sessions. So I'll open that up to the group, and we greatly appreciate if any of the members can share, either one or even two or three take-home messages and or any questions that they might have for any of the speakers so far.
Hi, everyone. This is Carolina. Can you hear me?
Yeah, that was a good pregnant pause. Thank you, Carolina.
Yeah, sure. I'll help you guys out. Okay, so my three take-home messages are that data is important, and I need to think about how I can really document this so that I can prove, that it works, that the model works. Also, that quality improvement. I'm very familiar with the PDSA model, but it's always good to see it in different forms, and so I think that quality improvement is going to be a good step. Also, in thinking about sustainability of my program. And the third thing is that we finally found a common definition for PECC, and so congratulations to everyone who agreed on pushing this forward. So those were the three things that I learned today. I hope that was the question.
That was really helpful. Thank you. Anyone else want to share anything? Thank you, Carolina, for helping us out with that. And that was a nice summary, and those match fairly well with the objectives we were trying to get across. My comment about the definition would be that this is allows for some adaptation and is still fairly broad. So while it is great to have a unifying platform for this role, it does, within that definition, allow for some flexibility and adaptation to different contexts within different parts of the country. Any other comments? We'll take another brief pause here if anyone else has any other take-home messages that they would like to add, and then we'll move on.
This is Catherine from New Mexico, and I just wanted to thank you guys for putting the IHI quality improvement modules up there. I don't specifically have any experience myself in implementing quality improvement things, not that I think they are, but now that I have an opportunity to learn more about it, I think I've been doing it. I just didn't realize it was quality improvement. So that was much appreciated today, as well as reiterating the Plan, Do, Study Act. And on that very first slide you had up, if you could put that up again, I'd love to take a snippet of the model so that I can put that into my presentation for the stakeholder meeting I have coming up on the 7th.
Well, this will actually be relevant to everybody on the call, but we're going to send the slides out to everybody too.
Awesome.
So you'll be able to get it. Yeah, sure.
Thank you.
And for those of you that have not had exposure, or even if you have had exposure to quality improvement, the IHI modules are a fairly efficient and effective way to get a refresher or to get a primer. So I know everyone's time is super valuable, but they are very well done, and it's great to have access to them. Excellent. Any other questions before we start to move on? And we're going to hopefully have a bit of an interactive discussion related to some barriers and facilitators and checking in. But any other take-home messages or questions? I'm hearing some great comments about a standardized definition being a great starting point, the quality improvement approach, and I would echo what was stated that a lot of this many people are already familiar with, but sort of refining your understanding and the language that is sort of standard within that world is a great opportunity through the HI modules.
And just to answer a question that was submitted via chat from Martha in New York, and I'm making this vocal to the whole group as it might apply to others, but she stated that she actually started the modules a few years ago, but weren't able to finish them, and if she logs in, will she just be able to pick up where she left off? The honest question or answer to that question is I don't know, simply because they renew every year and we get a new access code. So while you might still have an account with them, I'm not sure if your progress was saved under a former access code. But you're welcome to log on and you can use our access code. It might just have you renew it and pick up where you left off. But that's the best answer I can give to that question.
Thank you. So I think we can go to the next slide. So really our hope now is to take some of the information that we heard from Travis and Cassidy and others on the call today and begin to process that in real time here and discuss either barriers that people have experienced or opportunities that they see within their state. So we have 9 states, a diverse set of experiences. Certainly, I think a helpful place to start is barriers. Opportunities are a nice thing to try to remain cup half full and positive. But I recognize that all 9 states that are participating, are aware of the opportunities and enthusiastic and passionate about this work. So a reasonable starting point may be to share either barriers that are lived, so barriers that you've experienced already and beginning to discuss this with stakeholders or your team, or barriers that you have concerns about. And we're hoping that on each call we can share those and allow for some learning across the different states. If anyone has a barrier they're willing to share, again, we'll go with a bit of a pregnant pause here, and hopefully we can have some dialogue and hear between states here as opposed to just from the faculty.
Hi, this is Jason. Go ahead, Catherine.
I bet you're going to, no, we were just on the same call together, so you go first, please.
No, okay. Like she said, we've discussed this a bit already, but one of the barriers that I'm running into as far as one of the first steps in our work plan here in Montana is to develop a baseline from those that have had success designating a PECC. So we've developed a short survey, less than 30 questions. It takes about 20 minutes to go through. And we've identified about 43 of our statewide agencies out of 192 that have been successful or at least claim success in having a PECC. I've made multiple attempts to contact them, a few in person, and then everyone by email and phone. I've left a lot of messages. I've just gotten a lot of no responses. I had one response where the person who had been designated the PECC had a lower-ranking firefighter call me back in a very suspicious manner, wondering really what I wanted and was I trying to sell them something, and explaining that apparently this was the busiest person in the state of Montana and may not have time to take 20 minutes to talk to me. So just for me, it's going to be a challenge in gathering this information and in getting folks to dedicate some time to even discuss the possibility of or the how they have a PECC now or the possibility of developing one in the future. One of our biggest challenges is Montana's EMS providers are about 85% or greater volunteers. So we don't really have a staffed office that we can just pop into from time to time and get some face-to-face contact. It takes making appointments and asking for more of their limited time. On the other hand, we have had some great success with a lot of folks who are incredibly willing to share their time or looking for training and things like that. But just getting these folks to even respond in many situations has been our biggest challenge.
Thank you for sharing that. So I'll open that to the floor, and then I'll provide some comments after. Does anyone have any comments on if I tried to summarize that question? People or that barrier is people stated that they had a PECC or had an interest in a PECC on the survey. Going back and cross-checking with those people, sometimes they're very difficult to track down, or they may not understand what the collaborative is. I don't know if that's a reasonable summary. So I'll go first. This is Mark. I think that one of the challenges may be that this question was embedded into a much larger survey, and they may not see the connection between this survey and you reaching out. I think that's pretty clear to me when there's a concern that you're a proprietary person. And really the first phase of this work needs to begin to create that community of practice and trust. So with people that are already doing this, get an understanding if they are willing to share, and our hope would be getting them the feeling that they can share their successes as well as potentially benefit from the shared learning within that community of practice. So hearing about what people are doing in other states and or in their state. In states that have reached out or are considering reaching out, any other strategies or ideas on how to do this? I'm thinking even potentially some scripting of, how do we connect our phone call and contact to them related to this collaborative to not only the survey and our work, but to their everyday work.
So this is Terry, and Carolina, I'm going to share one of the strategies that you used. I'm not sure how well it would work in Montana, but in Rhode Island, Carolina essentially used an intern to be the harasser so that she could have time to do the other things she needed to do. And since we have such a short timeline, I don't know if that's an option. If there's someone from the university, I know there might be people interested in this who could help you with trying to track folks down.
Well, this is Robin in Montana. I also just sent out an email to the listserv explaining what Jason was doing so that he wouldn't be considered, trying to sell something. So that was something I should have done earlier, and I just did that when I realized that he was having some barriers that way. So in other words, I should have gotten the communication out there earlier to say that he was coming. I mean, I have in smaller groups, but not statewide. So that's something I will work on as well. And Jason in Montana is our pediatric liaison. He's our contractor, so he is the one that will be doing the lead on this. But in my job as the program manager, I need to be able to help him out as much as possible in that way.
Yeah, this
Thank
is
you for sharing
Carolina.
that.
Oh, sorry.
Kathleen Adelgaze.
Oh, no, go ahead, Caroline.
Yeah, so I did. We can hear you, but okay, you can go first.
Oh, I'm so sorry. I apologize. My only thought on that is I completely understand the issue of a short timeline and a designated individual who has a sole focus on this. But one project that we were involved in with evidence-based guideline dissemination at the statewide level, having a local champion was key. But when that local champion was somebody who was doing it from an academic focus or something else, when they left the position, there was a lack of sustainability. And so I think that in having identified an intern or an academic person or somebody doing capstone or a contractor, that's all a very perfect way to get it off the ground, but you need a longer-term sustainability plan as well, because once that person leaves that position or that role, things tend to fall apart.
Yeah, thank you. I think that was Kathleen. So thank you for that. I would say that from what I'm hearing from Montana, this seems more like just getting those people to provide some information about what they're doing. So I hear your comment, Kathleen. I think it is important in states that have contracted some of this out to think about long-term sustainability and how to create a community of practice. So thank you for that comment. Carolina, what was your comment?
I just wanted to expand on, but Robin already kind of said it, and I just wanted to, so I did have an intern who was the harasser, but I did preempt, like I introduced her to everyone and let them know that she would be contacting them. So when she did, in her first email, she did say, you know, I'm within the Center for EMS representing, you know, I'm writing on behalf of Carolina Roberts Santana. So there was that where they already know who I am, and so she was coming in as a representative of our center and a representative of the EMS for Children program. In terms of what Kathleen said, I agree. I mean, personally, for me, sustainability for this is within my EMSC program, and I think this is like an initial startup for a lot of us, where once, in terms of my program, once I get people trained, or, you know, the sustainability piece is going to be a smaller part of it versus this initial, I think this initial startup requires way more people than one person.
Yeah, and coming back to, again, the purpose of this initial contact in Montana, and I believe this is happening across all 9 states in some form or fashion, it really is a cross-check of people said this on the survey that they had this PECC or an interest in a PECC. I would recognize and bring to this group some of the challenges with survey-based science and some of the challenges with the National Pediatric Readiness Project on the hospital side, that sometimes people check things on a survey and they maybe should not have checked it. So if an individual is not interested once they find out who you are, or really they don't have a PECC from what your understanding of a PECC is or definition is, I would encourage you to move on and try to find those individuals that are actually having people functioning in what you foresee as a PECC and want to have as a PECC in your state or region. If there are none of those individuals, then we would work to connect you with individuals in other states or regions that are participating. But I do want to make sure to be clear that based on the other projects that we have done related to a survey, people had said we have a hospital-based pediatric champion or pediatric care coordinator, and there were experiences where either that person was no longer with the organization or the interpretation of that definition maybe was not the same as what we intended it to be. So I think one piece is making the connection with this individual or this agency. The other piece is figuring out if what they perceive this definition is actually what you thought it was. So I am curious with places that have connected with people, and maybe Carolina or any of the other 8 states outside of Montana, how are you going about getting that information from them in terms of opportunities, I guess? So what information are you getting? Are you meeting with them one-on-one? Are you going and following them around or having your intern do that? Like what's, I know we're really early, but has anyone actually done that yet?
So I haven't done it for this is Carolina. I haven't done it for this specific cycle. I want to call each quarter kind of like a renewal life period because things change in a quarter. But the outreach that we did in January of this year, we were able to increase from the original 13, we received information for I think it was 29, so that brought us up to about 41. So I'm in the process now of contacting those individuals and the agencies to make sure, that they're willing to fulfill the role and that they're going to participate in the training. But that's something that I'm still trying to finalize other program details before I take that step.
Thank you. And I don't want to put her on the spot, but I'm going to. I'm not sure if Vicki from Connecticut is on, but I think one of the approaches that Connecticut was taking was a little bit of a let's figure out exactly what a PEC is and what these individuals want it to be related to that role moving forward. Vicki, are you on? So she may have been having some issues with audio. Vicki, are you there?
Yeah, can you hear me, Mark?
Yeah, go ahead. Thank you.
Oh, good.
Thank you so much. I know you're having some issues with audio, but I think that Carolina's comment about how she's been approaching people is an excellent approach. I know that you've had a little bit more of a let's form this definition together with you. If you just want to comment on sort of how that experience has been going and your interactions with people that commented yes in our state.
Sure thing. One thing that I've been doing for the past year since I've had this role is I monthly attend the EMS advisory board meeting, and I've made a lot of great connections there. And then from there, any EMS event that we could try to have a presence at, we do. And I understand being a smaller state, we have a bit of an unfair advantage over your bigger states, because we can actually travel around and do a lot of this stuff. But as much as I can, I try to meet with people one-on-one. I had a really productive meeting this morning with one of the EMS coordinators who has a PEC in place and has several people that could potentially be interested in helping out with the program. So we kind of formulated a game plan that for that area of the state, they're going to be kind of our home base. And from there, we'll outreach to the different BLS, fire, and EMS, and hopefully even some of our police officers, because they first respond to most medical and trauma emergencies here in Connecticut. So it's just a lot of relationship building and a lot of listening to what people want, because it's going to be different depending on whether they're a rural volunteer department, if they're a paid department, or depending on how active their volunteer groups are. I know, unfortunately, as in most states, our volunteer base is kind of shrinking here. So that's one challenge as well. But I really think there's a lot of people interested in helping out. It's just, finding what they're able to give without overwhelming them with this new role.
Thank you, Vicki, for sharing.
Mark?
Yeah, go ahead.
Mark? Hi, this is Donna from New York. One of the things I wanted to share is we have a very large state, 1,700 agencies. So one of the things we're very fortunate is we have approximately 18 regional EMS program agencies who already have established relationships with a lot of their agencies. So our goal is to hopefully outreach to them and utilize them to be kind of the conduit to the agencies, which again, more that grassroots type of atmosphere is what we're hoping to build.
Excellent. So from what I'm hearing from both of those states is sort of this concept of leveraging existing relationships, but also leveraging existing infrastructure or meetings as places to, synergize and potentially, have some structure and processes in place. Thank you. Any comments from any of the other states? I feel like we've heard from about half. Well, thank you to those states that did share. We are a little bit nervous with a webinar like this that it would just be a pregnant pause for the last 15 minutes. So thank you for some interactive discussion, and we really appreciate it. If anyone has any additional barriers or opportunities or strategies, we'd really appreciate if you could email those along to Sam, and our hope would be to try to put together like tricks and tips kind of sheets or even just experiences that we could share. And I think this first step of creating the community of practice and engaging with stakeholders can be quite frustrating. It can be quite rewarding once you're successful at it, but certainly from other collaboratives I've been involved in, people sort of telling you off, so to speak, is disheartening when you're really trying to help them. So try to keep the optimism going and recognize that we're all in this together to do the right thing, but we may encounter some barriers as we try to work with pretty busy people who may not know what our motivations are. So thank you for sharing, and I think we can move on to the next slide towards the wrap-up here. Thank you.
I believe that is our last slide.
Okay. All right. So that is our last slide. Thank you. So with that, I guess we will open the floor for any other questions or comments, not just barriers or opportunities. Sam, maybe if you want to let people know about upcoming activities or any other information related to upcoming webinars.
Sure. So not hearing any other questions. So our next learning session is going to be on November the 15th at 11:30 a.m. Central Time. You all should have received the Outlook invitation for that. If you have not, please let me know, and I'm more than happy to forward that to you. I know that my group and Terry's group have had their pulse check. I believe Rachel's group may have had theirs this morning, and we will be contacting all of you to set up additional pulse checks here as we enter into the month of November. And at any time, if any of you have any questions, comments, helpful tips, whatever, we'd like to hear those. And this morning I did send out the introductory packet to all of you with a link to our webpage that has many different resources available on there. It is a living webpage, so we will add documents and resources as they are developed and as we gather them. One of the things that we are trying to develop is kind of a chat room to where you all could post messages to each other, but that's easier said than done. So anyway, so yes, and that's all I have. So if there's
Thank you, Sam, and thank you again to Travis, Cassidy, and Tony. We really appreciate the hard work that you put into creating those slides. Again, the slides will be sent out. This webinar is recorded. If there are other members of your team that you'd like to share these resources with, that recording will be sent out to you and the slides will be made available. And just to come back to the IHI slides, again, the people on the call are aware of that now, but I would encourage you to share that information with the IHI training, to share that information with others who may begin to get engaged in the collaborative, potentially some of your super users or champions.
And those resources are free to all of our PECC collaborative folks, so definitely utilize those if you have them.
All right. Well, I guess with that, we'll end about 30 seconds early, and really appreciate everyone's time and commitment to this project, and we look forward to hearing about the continued successes and potentially helping each other to address the barriers. So thank you again, and have a great day, okay?
Thanks a lot, guys. And I'm sorry, I just wanted to say to Victoria, your question, let us do a little work on that, and we'll get back to you. I didn't want you to think we were ignoring you.
Okay, no problem. Thank you.
All right. Take care. Thanks so much. Have a great day. Bye-bye.
You too. Bye-bye, everybody.